5 minutes more for us to go live. So once you go live on YouTube, yes, we'll start letting the participants in. Shilpa, please.
Are we live on YouTube, Shilpa?
Yes.
Okay.
Shilpa, you can play the AMSI web series music, please. Good evening, everybody. Welcome back to AMSI web series. I request all participants kindly mute. Please don't on your video. Kindly mute. Thank you. Kindly make sure that your video is off and kindly mute so that it doesn't disturb the speakers. Thank you for joining AMSI web series today. Today, other than the topic, this is also a very special day for all of us. It happens to be birthday of our past president, Dr. Sanjeev Nair, the vice president-elect of IOMS. On behalf of AMSI family, we wish you very happy birthday, sir. Shilpa.
Thank you. Oh, come on, Preetham. Preetham, you have to do it.
Happy birthday to you. Happy birthday to dear one. Happy birthday to you.
Thank you. Over to you, Kannan.
Hello, everyone. A very good evening. It's with great pleasure we are welcoming you all to the next Aomsi web series, the fourth one of the series, and we have an important topic today. It's a pleasure to introduce the co-hosts for our series. As you will be aware, we have two co-hosts for YouTube and two for Zoom. The co-hosts for YouTube today are Dr. Srijan Mukherjee. Dr. Srijan, do you want to say hello? Dr. Srijan Mukherjee is from Calcutta. Yeah, there he is. So, and then Dr. Adarsh Kudwa. Dr. Adarsh is from Manipal. Hi, Adarsh. Yeah.
Good evening, everyone.
Okay. And then we have two co-hosts in the Zoom platform as well. We have Dr. Taranjit Kaur. Dr. Taranjit is from Jamnagar.
Hello, everyone.
And we have Dr. Shubhra.
Welcome to the gathering. Yeah.
Dr. Shubhra is from Chennai.
Good evening, everyone.
Thanks, everyone. Over to you, Amit.
Thank you, Kannan. So, without wasting time, it's a pleasure to introduce the distinguished speakers of the day. So, we have first speaker with us. Everyone knows him, Dr. Moni Kuriakose. So, sir will be speaking on role of oral and maxillofacial surgeon and a dental surgeon in early detection of oral cancer. We welcome you, sir, Dr. Moni. The second speaker of the day is Dr. Anthony Poggle, and he's a famous oral and maxillofacial surgeon, professor and chairman from California, and he'll be speaking an American perspective as well as latest technique in early detection of oral cancer.
Morning, everyone.
Speaker,
Just call me Tony.
Thank you, sir. Thank you. We welcome you, sir.
Thank you.
The third speaker of the day is Dr. Parveen Birur. He's from Belgaum, and he's in the specialty of oral medicine and radiology. Hi, Dr. Parveen. He'll be speaking on point of care in oral cancer.
Hi, good evening, all. Nice to be here. Thank you.
We welcome you, sir. The fourth speaker will be Dr. Neerab Trivedi. He's a well-known surgical oncologist and head and neck surgeon from Gujarat. He will be speaking on digital platform and applications in early detection of oral cancer. Hi, Dr. Neerab. We welcome you.
Yeah. Hi, everybody. Yeah, best wishes. Thank you.
Yeah, and Dr. Pankaj Chaturvedi will be joining us shortly because he has got some meeting with the Chief Minister of Maharashtra due to this COVID spike of cases. So we are expecting him to be there by 7:30 or 7:45. He will be taking the panel discussion along with Dr. Sanjeev Nair. Dr. Sanjeev Nair, everyone knows, he is the director of head and neck services in BMJN Hospital, Bangalore. Hi, sir. So I would like to invite the first speaker of the day, Dr. Moni Kuriakose, to share his screen and start the webinar. Thank you so much, sir.
Thank you, Amit. I hope you can see my screen.
We can see your screen, sir.
Okay, thank you. And first of all, let me thank the Aomsi for the kind invitation for this important seminar. Really glad to be joining the seminar with a lot of very illustrious speakers. So the topic assigned to me is to discuss the role of dental and oral and maxillofacial surgeons in the management of oral cancer. And if you look at the title of the very symposium, is oral cancer is a preventable and a potentially curable cancer because of three reasons. First, we know the cause of oral cancer, and early detection is possible, even though we're going to hear some technology. What is basically required is one pair of trained eyes, and then it's curable if we diagnose cancer at an early stage. And what's the role of dental surgeons in this, all these three aspects? In all the three aspects, we can play a major role. In cost, we can play a significant role in risk reduction. Pankaj and others will discuss about that. What I'm going to focus is the early detection aspect, how we can play a key role. And thirdly, surveillance supportive care. Neerav is going to cover that topic in detail. First of all, let's look at the problem. So this data is from Dr. Cockrell's country, US. If you look at this, is an entire head and neck cancer, not just oral cavity cancer alone. And this is the incidence of head and neck cancer from 80s to 2006. And if you see, look at that, there is a steady but slow but steady decline in incidence of head and neck cancer. But what is alarming is this fact. And if you look at the locally advanced cancer, that number is going up. And this data is from US. Now, if you look at the outcome, what is happening, we saw that the stage is increasing. What's happening, the outcome? If you look at the entire head and neck oral cavity subsides or head and neck subsides, the overall cure rate has almost increased by 10%, a significant increase. Similar incidence or improving outcome is happening in the oral cavity cancer too. And coming back to India, let's look at what are the change in the incidence. This study is published recently in 2018 from 1990 to 2016. And this is a league of all the cancers. The lip and oral cavity came to the second point compared to third. But if you look at the actual absolute incidence, it has come down. It's about 6% when it comes to lip and oral cavity. Larynx, look at the larynx, it has come down about 30%. And if you compare this to US population and compare that to larynx, so what the net effect is that if you know the risk factors, if there's for society or disease with a high prevalent habit, if you reduce the risk habits, the incidence will come down, as you can see from this data. Now, coming to my theme of my talk, what's the importance of early detection? In 2003, I moved back to India, took up a job in America. And my research focus till that time was looking at some kind of tumor immunology to look at how immune system can be modulated for cancer control. What really changed my outcome and my outlook about research and the approach towards cancer was this paper. This is one paper I really quote all the time. So I thought that it's maybe a good thing for you to understand too. This study was published by Shankar Narayan, one of my mentors, and he looked at the outcome in US versus Indian population. I want you to focus only on the last line here. The overall outcome is about 20% lower in India compared to US population. And if you dig deeper into that data, you can see that when it comes to loco-regional disease, where you need multimodality treatment and so on, the outcome is even poorer, about 26% poor outcome in India compared to that of US population. But look at the localized cancer. If you detect cancer at an early stage, the outcome in India, in Mumbai, compared to a US population, almost exactly the same, 7.3% difference that was not statistically significant. So rather than spending all the resources, all the immunotherapy and all the high-end radiotherapy, if you just detect cancer early stage, we can get similar outcome as that of any other country in the world. So that is where we need to put the resources. And again, looking at how that stage determines the outcome, again, this is a comparative outcome from US versus Indian population in head and neck. The outcome in India is about threefold higher, mortality threefold higher in India compared to US. that can be primarily directed towards the stage at which cancer is diagnosed. Almost 90% of cancers are diagnosed at stage 3 and stage 4. So let's look at why this is happening. Okay, I'm going to make a problem statement here. I'm going to say that the primary reason, or one of the primary reasons for this delay in diagnosis are the healthcare providers. And if you look at the maze, the route the patient has to take to from the symptom, and they have to see the primary care doctor, go to district hospital, medical college, cancer center, and so on. And if you look at the different encounters this patient have to take towards treatment, it's fairly complex. And that system is what causing one of the major delay in cancer treatment. And this was confirmed by one of the speakers of this session, Dr. Chaturvedi. What he did was he looked at 200 oral cavity cancer presenting with T3 and T4 stage, and looked at this, how long the symptoms had, what's the delay, what's the contribution of the delay by the patient, primary care, and other paramedical type of situation. And if you look at the percentage, average symptoms about 7 months, and if you look at the delay by the patient, about 52%, and delay by the primary care is almost similar percentage of delay is happening. And the primary delay, that is delay from the onset of symptom to seeking help, was about 2.7 months, and secondary delay after seeking the first point contact of the doctor towards the specialist treatment was 1.9 months, and from the specialist treatment, the contact to start of treatment is about 1.4 months. So overall delay of 6 months. So we as a medical community playing doing an active part or is contributing towards that delay. Now the question is how to avoid that delay, or how to improve that delay in diagnosis. So that is this is going to be the main focus. I'm going to focus. As I mentioned at the introductory comment, what is required is one pair of a trained eye. So let's train ourselves and see how we can make the diagnosis. You know, for a cancer doctor like me, I see only, most of the time, I see only cancer in my clinical practice. So if I just look at these lesions, I can easily pick and say this is a cancer lesion compared to many other lesions. But if you put yourself in the shoes of a primary care physician, they have to see all kinds of things, a benign ulcer to an oral potentially malignant lesion, as well as some of the normal anatomic variation. So differentiating one from the other is extremely important. Let's learn that. So this table, I know it's confusing, but let me just take you through this table. This is an important table, very simple table, but it's important for us to avoid making error. So if you look at the 3 or 4 groups of disorders, we need to look at the symptoms and some of the examination findings. So if you look at the symptoms, almost all the benign lesion will not last more than 3 weeks' time. So duration is important. Oral potentially malignant lesion will be months, and the malignant lesion will be only weeks, as you saw from that previous studies about 6 months period. And the normal lesion, of course, it's a year long. And the previous history, most of the benign lesion will have a previous history, and pain is not a major issue when it comes to oral potentially malignant lesion or in a cancer at early stage. Examination, one of that, I'll come to that when I show different lesions. We can get some specific features of the benign lesion which will help us to identify these lesions. Now let's look at the benign lesion. It's a long list. I don't want to go through all the list, but some of the common lesions I have outlined here. Look at some of the common lesions after ulcer just by looking at the bright red lesion and recurrent nature is almost diagnostic of after ulcer. But look at in the eyes of a of a busy clinical practitioner in the primary care setting sometimes can be challenging. Traumatic ulcer, again, there's been necrotic kind of base. You can see that pemphigus kind of bullous type of lesion, recurrent nature, and the lesion with a bullous or peeling off the mucosa are characteristic of these lesions. Now, other benign lesions which can confuse are dental hyperplasia. Sometimes people overdiagnose them as malignancy. This can be identified by the typical feature as well as location. Atrophic candidiasis, that can be confused with the oral potentially malignant lesion. Peripheral giant cell granuloma sometimes get confused with the malignant lesion. The lichen planus, it's an important diagnosis to make, and distinguishing that from oral potentially malignant lesion is extremely important. We need to look at some of the typical features. That's a Wickham's striate, that the white striations at the border, and associated with significant burning of the lesion of the mouth is typical of lichen planus, and relapsing nature of the lesion as well as associated dermatological manifestation needs to be elicited. Oral potentially malignant lesion, that comes in different clinical varieties, a homogeneous leukoplakia or erythroplakia. In this particular patient, there is a invasive squamous cell carcinoma. 2 can be identified. So this lesion can be diagnosed just by clinical examination, at least making a clinical diagnosis. Of course, you need to confirm by histological confirmation. Now, oral proliferative varicose leukoplakia is much aggressive version of the leukoplakia, can be identified by the varicose nature of the lesion. And now the question what the most of the clinicians, the community need to recognize is how to stratify this lesion from a high risk versus low risk. Most of the time, there are about 6 features we can take to differentiate a high risk versus low risk. One is the duration of the lesion, more than 2 years, size of the lesion, more than 2 years, site, tongue, and flora of mouth, and non-homogeneous type of that lesion, and lack of risk habits or presence of high-grade dysplasia. Now, coming to malignant lesion, there are typical sites in which oral cancer develop. And one of the typical sites in the tongue is a junction of the posterior 1/3 and anterior 2/3, and just anterior to the forehead papilla. This is the area we need to look. And when you do the routine clinical examination, pay attention to this particular area. Then the buccal lesion, just by looking, we know that this is a malignant lesion. There is no need to prescribe antibiotics, anything, just clinical diagnosis what is required, and the confirmation by biopsy. And 2 other lesions can be shown in the alveolus. Use the finger to find out the induration as well as tenderness to differentiate. Another group of lesion which can confuse us is the normal variation for the granules, which I showed you earlier. You just compare right to left side or the longevity of the lesion. You can differentiate this from any other pathological condition. Another the lesion, or no, I could not call lesion, another anatomical variation which can confuse the malignancy is the forehead papilla. Sometimes that can be more red because of some kind of local inflammation. But all we have to do is compare right from the left, and a particular location we can identify or diagnose this as a normal forehead papilla. Then normal variation, fissure tongue, hairy tongue, and geographic tongue, these can be identified from the typical features. One of the take-home messages is that any ulcer which lasts more than 3 weeks' time, we have to assume it's a cancer. Just to summarize the management of oral lesion, Dr. Popel is going to discuss in detail. First, you differentiate whether it's a potentially malignant or non-malignant lesion. Non-malignant, as we saw earlier, just follow up. Potentially malignant lesion, differentiate into low risk versus high risk. Low risk need just follow up. high risk needs a biopsy, and we have seen that features suggesting the low risk versus high risk. And biopsy is extremely important to differentiate one from the other. Dr. Pogra will go into details about that. How to examine the oral cavity cancer? This I do not have to explain this to this audience, but let me just quickly go through for completion's sake. Thorough head and neck examination is extremely important. Almost all the oral cavity cancer will have metastasis level 2 or level 1 region. Pay attention to this area, and we have to appreciate that these lymph nodes are along the internal jugular chain. So you need to put your finger deeper to the sternocleidomastoid muscle to feel for that the lymph node in the level 2 and level 1 region. Look at the anterior floor of mouth, lower lip, upper lip, right buccal mucosa, left buccal mucosa, and pay attention to this area. This is a very, very common area where you can develop cancer, as you have seen that picture which I showed you earlier. And the other side, and the dorsum of the tongue, very rarely you see cancer. And then the roof of the mouth, squamous carcinoma is rare, and the floor of mouth is very common area for cancer. Last point is a biopsy. One of the important message I want to convey this is that a number of most of us do biopsy, but many of us do not do treatment for this lesion. So do not do an excision biopsy, just do an incision biopsy. It's extremely important. Otherwise, after excision, the wound will heal and the treating doctor will not know where to do the surgery or appropriate treatment. So finally, to summarize, ladies and gentlemen, we looked at what are the distinguishing features of the benign, potentially malignant lesion, and some of the normal variation. How to differentiate a high risk and low risk was discussed, and a basic treatment plan was outlined. And then the last take-home message is that any ulcer in the oral cavity which lasts more than 3 weeks time, we have to assume it's oral cancer. Thank you very much for your attention.
Thank you, sir. Over to our next speaker. Shilpa, can you arrange for the next speaker, please? Yeah.
Good morning. Welcome from San Francisco, where it is 5:30 in the morning. This is a lovely view of our campus, taken by one of our residents using his personal drone before he was told that was illegal to do that. But I still use his photograph because it's one of the best ones I have of our campus. As Moni said, the World Health Organization made a differentiation in 2007, between pre-malignant disease, where virtually all of them are going to become malignant if you wait long enough, versus potentially malignant disease, where some of them might become malignant, usually a small number. And it is important to differentiate these two, and I will itemize both of them. So let's move on. Oral cancer very rarely starts from nothing. That usually you see dysplasia first. Now, dysplasia is a histological term. It's what the pathologist sees under the microscope. What you see in the mouth is usually either a white patch or a red patch or a mixture, a speckled patch of red and white. And you biopsy it and you get the diagnosis of dysplasia. And most pathologists try to categorize that dysplasia into these 4 categories: mild, moderate, severe, carcinoma in situ, and then frank carcinoma. And what we struggle with is how do these relate to each other? Do they change from one to the other? Or can mild dysplasia go straight to cancer? And we're beginning to get one or two answers to those problems. And this is what's often shown as mild dysplasia in the top left, going to severe dysplasia in the bottom left, and frank carcinoma on the right. And the feeling is that most cases do progress from mild to moderate to severe dysplasia and then go on to form oral cancer. And the feeling is that probably about half of them will eventually become malignant if left long enough. And long enough might be 20 years. There is also a feeling, however, that some cases of mild dysplasia can in fact progress straight to oral cancer. So it is important to get at these mild cases early and either observe them so that if they do transform into moderate or severe dysplasia, you can act accordingly. Or some people like to just excise them straight away if it's a small area. And from a couple of multi-center studies in the UK, where patients are fairly closely monitored, we are getting some figures now of oral dysplasia transformation rates. And you see them there, that 22% of cases transformed into malignancy over a 5-year period. With tongue cancer and floor of the mouth, it may be as high as 40% that progress to become oral cancer. And that of the mild dysplasias, 5% progressed. So not as big a problem, but you can't just ignore the mild dysplasia. So the question is, do we just look at them and see what they look like and biopsy them? Or is there anything that can help us? And I want to show you some of the things that we have available to us in the United States. I'm going to show you that they're not necessarily any use. I'm going to tell you they're very heavily marketed by the manufacturers. There's a lot of hocus pocus attached to them, but let's look at them and see just what is available and whether they might be of any use or not. Now, toluidine blue has been around since the beginning of time. It is nothing new. People have used it for 50 years. It is now available commercially. You don't have to mix your own anymore. And you apply it to a lesion in the mouth that you don't like the look of, like that. So there you have something. And you know we don't like lesions in the floor of the mouth. They worry us a great deal because they have a higher malignant transformation rate. So when you see that, you know you're going to biopsy it. The issue is you don't know where you're going to biopsy it. Could be on the right, could be on the left, could be in the middle, could be all three. And this is where toluidine blue, or in Europe, they use Lugol's iodine for the same purpose. You can stain it with the toluidine blue. You can counter stain it, either with a cup of coffee or 2 cups of coffee, or with acetic acid. And the areas that retain the stain, where it doesn't decolorize, are the suspicious areas. And those are where you're going to do your biopsy. So what toluidine blue does is it tells you where to biopsy. It doesn't tell you what the result is going to be, but it tells you which bits. And it might not be the bit you thought. The bit in the middle, it doesn't stain. It's the bits on either side that stain. The stain itself is taken up by nuclei near the cell membrane, which means malignant cells, potentially malignant cells, hyperactive cells of any kind will stain with toluidine blue or Lugol's iodine. but they tell you where to biopsy. And that's what we did in this case. You can see we've taken 3 punch biopsies, and we'll go into that shortly. Now then, 15 years ago, we were introduced to what's called the brush test. Oral cytology has been tried for years. Cervical cytology on the female cervix is well established. You can scrape the cells off the surface, you can look at them under the microscope, and you can make a diagnosis of cervical cancer or cervical instability. The mucosa in the mouth is very similar to the female cervix, so people have tried over the years to scrape the cells off the surface benignly and just look at them under the microscope. It has not been as successful in the mouth because there's a lot of debris, there's saliva, there's food, there's all sorts of stuff there, and it's very difficult to differentiate. And what's made the change is computer technology. So what this company does, Oral CDX is the name of the company, they give you a special brush, which they say will get the right cells from the basal membrane. You brush the tissues fairly aggressively. One disincentive has been that you have to plate your own slide. And most dentists have long since forgotten how to plate up a slide. So this technique has not been particularly popular. There is a group of dentists and surgeons who like to use it. Most do not, because you have to plate it yourself and then put it in an envelope and send it to the company. They put it under their high-powered computer software, because this is what you see on that plate, and it's impossible to differentiate what you're looking at, but the computer can do that, and it will give you that from that. They will give you the cells that look peculiar, and you will get a diagnosis back to say, yes, these are potentially malignant cells, or these are severely dysplastic cells, or these are frankly carcinomatous cells. And this is what they send you back. So you do get a result, but it's not proved to be a popular technique because it is technique sensitive, and you still end up at the end of the day doing a conventional biopsy. You can't trust it enough to say, I don't need a biopsy for my pathologist. And you do get some false positives and false negatives, which you don't get from a formal biopsy. And in fact, here is an article in OOO from 2008 from some authors in India showing that, in fact, you don't need a computer. They were proud of doing it without a computer and with an ordinary toothbrush, and claiming they could get just as good results as the company Oral CDX could get with their $5 million computer. So possibly you can do intraoral cytology without a computer and with a regular toothbrush. So that technique is available, but not particularly popular. There is a word, chemiluminescence, which is a kind of made up word. And what it means is there is a company, Visilite, who have come out with a tube which, when you break it, releases chemicals which transmit light. And the claim is that if you're in a darkened room and you break this tube and shine it in the mouth, it will show you areas of dysplasia that you might want to biopsy. It's a bit strange doing it in a darkened room, drawing the curtains and switching the lights off. I am told that this technique was derived from these party tricks that children have, where they wear these tubes around their necks and they break the tube and the liquid mixes together and gives out this strange light of different colors. And some enterprising, actually he was a gynecologist, I think, originally, made this technique for looking at both cervical cancer and oral cancer. So this is available, heavily marketed by the company. They have some interesting literature that you can read. When you look at their photographs, and I assume they're showing their best cases, why would a company want to show their worst cases? It's not convincing that it is any better than just using a headlight and having a good look for yourself. And in fact, authors that we trust, and you don't trust anybody more than Dan Laskin, has written an article saying that in fact it is more accurate to use a headlight than to use this so-called chemiluminescence. And there are two companies, Visilight is the main one, but there's another one that tries to convince you that their technology is better at spotting pre-malignancy than naked eye. Probably not true. The next technology we have is the Velscope. This is very heavily marketed. It comes from Canada, actually co-sponsored by the British Vancouver government and also the University of British Columbia in Vancouver. This has a little more science attached to it. This uses fluorescent light. And this is the latest version. It's now hands-free. It's a good marketing tool. Patients love it. They're prepared to pay for it for oral cancer screening. The question is, what's it actually doing? It transmits fluorescent light on a single wavelength. And the idea is that the light will hit the tissues, you shine it into the mouth, and it will be reflected back. So you will get a blue light reflected back. However, they say that if the lesion is dysplastic or malignant, the light will be absorbed by the lesion and it will appear dark. So the light will not be reflected back. It transmits light on one wavelength. It comes from Canada. Americans are sure they can do better. So they invent their own instrument from Texas called the iDentali 3000. They always like to give it a big number. And it transmits fluorescent light on 3 wavelengths. Is 3 wavelengths any better than 1 wavelength? Who knows? But the Velscope has their literature and their advertising. And again, it's very heavily marketed. You see this pretty young lady shining this blue light into the patient's mouth and the patient paying quite a reasonable fee to have this done. And as I say, the philosophy is that the light will be reflected back by normal tissues and will not be reflected back by abnormal tissues. The question is, what are you actually looking at with this machine? Well, what you're actually looking at is hemoglobin. This light is indeed absorbed, but not by malignant cells or by pre-malignant cells. It's actually absorbed by hemoglobin. So you're looking at the blood supply. So yes, the blood supply is usually increased in oral cancer. It is increased in some dysplasias, but not all dysplasias. It is also increased, of course, in inflammatory lesions, in traumatic lesions. So you're going to get a lot of so-called false positives, and you're going to get some false negatives from dysplasias that do not have an increased blood supply. So there's a bit of science behind this, but it's not specific, as the manufacturers would suggest, for dysplasia and oral cancer. But it's very popular. And this is their marketing again. So again, you would think they would show their best cases, but I think I can see the lesions just as well with my naked eye as I can with their machine. I am not impressed by the results. Okay, I want to pass on to a couple of specific lesions which Moni has mentioned in a little detail. One of them is proliferative verrucous leukoplakia. We think this is a truly pre-malignant lesion, that if you leave it long enough, virtually all of them will become malignant. This has a very specific appearance under the microscope, and the diagnosis is a microscopic one, although the clinical appearance is distinctive. And it's just what it says. It's verrucous. It's like a wart. It's not flat. It's warty. And it progresses through normal to oral cancer through these stages. Regular leukoplakia, it becomes verrucous, it gets worse, it becomes a verrucous carcinoma, and it just relentlessly progresses. And sometimes it relentlessly progresses whatever you do. You can cut it out, you can laser it out, you can do all sorts of things, and it keeps coming back and getting worse. And we really don't have a good handle on this. There's what the pathologist sees, and that's how they diagnose it. These blunted rete pegs, the deep rete pegs, and the lymphocytic infiltration underneath. And you can see that on this one, it's already breaking out here. It's breaking out of the basement membrane, and it's on its way to becoming a cancer. This is carcinoma in situ here. This is proliferative verrucous leukoplakia. And this is its clinical appearance in many cases. And this patient's already lost the front teeth because of it, and now it's spread to the sides, and it's just relentless. This patient went on to have a wide, not a hemimandibulectomy, sorry, a marginal mandibulectomy, and it still came back, and it did eventually kill her. She was in her 80s when it killed her, but it did eventually get her. And this is a more verrucous form, and there's not much else looks like this. This is, clinically, you can almost say this is proliferative verrucous leukoplakia, but histologically it certainly is. Here's another one, looks the same. This is what you have to do. You've got to be aggressive. You can't just cut out this little bit. And in fact, she went on to heal very nicely. She wore a nice obturator, cum denture over it. She had 14 happy years. And you know something? After 14 years, it came back again and it killed her. So we do not have a good handle on what's going on with this lesion. We think it's probably a papillomavirus etiology, but nobody has identified the human papillomavirus that might cause this. It is not HPV 16 or 18, that we do know. And I'd like about lichen planus. Very typical reticular lichen planus. Felt to be benign, but potentially malignant, in that anything around 2 to 5% of them may eventually become malignant. For reasons that are not clear, they are commoner in relation to gold restorations. It's probably some kind of hypersensitivity reaction, but quite what to, whether it's the impurities in the gold, whether it's the cement that you use to cement them in, nobody is quite clear about what it is. It's supposed to resemble lichen, so that's why it's called lichen planus, I'm not sure it does resemble lichen, but we won't go into that. But here is a case with lichen planus in the cheeks and on the tongue. And this was observed for several years. And it's turned into an atrophic lichen planus. We don't like atrophic lichen planus, but without doing a full glossectomy, I don't know what we can do about that. And it did eventually turn malignant. So this was over about a 7-year period, and she died from this. So lichen planus can do this on occasions. It's only classified as potentially malignant, and that's true, but the odd case can become malignant. And Moni said if it doesn't heal in 21 days, biopsy it. Actually, we say if it doesn't heal in 14 days, biopsy it. Other people say 10 days, biopsy it. But the bottom line is, if an ulcer doesn't heal, biopsy it. We actually like to use a punch. Our pathologists like a punch biopsy. It's very clean and you get the depth. Our pathologists like to look at what's going on under the lesion. They don't necessarily want to look at the sides of the lesion. They don't want you to take the punch from an ulcerated area because all they'll see is a non-specific ulcer. They want the lesion itself and they want the deep tissues. So nothing, don't just do it skin deep. So a punch gives you very nice, clean edges, not traumatized, not gripped with forceps, and they can get a very good look at what's going on under this lesion. So our particular histopathologists are very enthusiastic about using a punch biopsy. And I just want to end up by showing you that we have a large Indian community in California, more in Southern California than Northern California, but we have a lot in Northern California. Many of them in the IT industry, of course, in high tech. They come over here and live their lives. Many of them bring their parents over eventually to live in California with them. And the parents have picked up some of your habits from India and they bring them with them. The young people don't do this, but the older generation, some of them do. Their children are always very ashamed of what their parents do and they like to keep quiet about it. But they will tell you that in the street markets, you can buy all the things that you can buy in India. And these are cases I have personally seen in California, not in India. So these are Indians living in California. And if you visit the street markets, you can find these. These are things that I was able to pick up in a street market with Indian stall holders. And even those as well, you can buy quite readily in California. So we are not immune to the problems you have from oral submucous fibrosis, but that's not the topic today, although that is probably a truly pre-malignant lesion. But if you leave it long enough, a great number of them will become malignant. And I'm just about out of time, but we do go into, patients always ask us, how do you avoid oral cancer? And you avoid it by not doing these things. But they don't like to be told, what don't I do? They like to be told, what do I do to avoid oral cancer? Don't tell me what not to do, tell me what to do. And we're not clear. The best we can say is maybe eat carotenoids and flavonoids and folic acid. Eating carrots might be good for you, although not everyone is agreed on this. But don't eat so many carrots that you turn orange in color. We can buy tablets of beta carotene and vitamin C or vitamin C, which quite a lot of patients like to take. Folic acid may be good, so we tell our patients eat lots of these things. Alcohol is bad for many reasons. It causes atrophy of the mucosa, but it also inhibits folic acid. So alcohol, we know, is bad for oral cancer, and the folic acid may or may not be good. But patients are taking something and they feel that's good for them. You can buy these juices which contain 100% of beta carotene, which is 400% of what you need every day. So if you drink this, you're getting 4 times as much beta carotene as you need. That should be adequate, just about without turning orange. So yes, our patients do ask us, what can I do to stop it coming back or to stop me getting it in the first place? And we tell them to do that. I spent many years going out to Trinidad as an external examiner, and the national bird of Trinidad is the scarlet ibis. There it is. It's only scarlet because it eats its flavonoids, because it's just a regular ibis. Here's an ibis from the adjacent island that's flown in. He isn't red. He's the same animal, but he's been eating a lot of beta carotene and he turns red like a flamingo. Where do they get the beta carotene from? They get it from this little crab. It's 1 centimeter in diameter, and they love eating these crabs, and they turn red. Thank you very much indeed. There's a nice view of San Francisco at night time. There is my email address. I am always happy to receive emails, and I'm usually quite responsive to them. So don't hesitate to contact me if you need to. I'll now stop sharing. So thank you very much indeed. Okay.
Thank you. Thank you, Dr. Pukrit. Yeah, next speaker, please.
Rita, can I call the next speaker?
Yeah.
Our next speaker is Dr. Praveen Biru. He is head of the department in the KLE Dental College, Department of Oral Medicine and Radiology, with 20 years of experience. His main interest lies in mobile oral health.
Taranjit, he's ready with his presentation.
Yeah.
Yeah. Can I start?
Please do.
Yeah.
Yes, please.
Yeah. Thank you. Thank you all. I thank AOMSI for having me here. What I'm going to share in another 15-20 minutes is about, I think it has a good continuity with what the earlier speaker has I've spoken about. And of course, Moni sir is my mentor. So we are going to do how we have approached downstaging oral cancer in India. And I do come at an early stage, at a precancerous stage, rather than I understand most of them are the maxillofacial surgeons. So what have we done, and what are the approaches, and how it has evolved over a period of time? So the slide sir also shared, I know we come from the same background. So the only key point which we started to address is, why do we have patients reporting to us late? And if they're coming late, how do we address that problem and see them early? So one thing which a delayed presentation, which I understand most of you are practitioners and understand there must be some general dentist as well. The most critical part in your practice is to have a good loop of specialists, from pathologist to a surgeon. This case, advanced case lesion, which reported running from pillar to post, it was so difficult to convince that his biopsy showed moderate dysplasia, and he still thought it's a precancerous stage and can be done. So there will be a lot of challenges which comes in our practice. It's good to have especially if you're a general dentist, to have a good loop referral pathway, which is so important to educate, motivate, as well as treat the patient at the earliest. This is again a sharp tooth which can be addressed at an early stage rather than waiting for that to become more progressive lesions. and early lesions, which all dentists have to very strongly believe that they can reverse it if you do it, intervene at an early stage. So this notion should be there very much, rather than being helpless that I can't do much when these lesions appear. Now, what we understand from all this is the simplest form for oral cancer is visual examination. And the most difficult thing in oral cancer strategy is it is too simple. It's too simple, so the dentist doesn't give much importance, neither the patients. So we need to get more action item into it. Economics has to flow in to make it more viable and sustainable for a long-term follow-up for the patients. Now, I always put this, the addiction of tobacco in your practice is so important. All that 5As, leave it. I leave it to the practicing dentist, whether they have time to do it. At least one question of, do you use tobacco, aracanate, or alcohol, for all the patients who visit to your clinic will create awareness. At least I think this has to be a mandatory for all the oral care physicians or a dentist to ask one question. Don't do anything more. At least ensure that you ask this question. The moment you ask this question, you have created some sort of an awareness of among the patients, because they all know they're doing something wrong. And if you just ask this, it creates an enormous impact on the patients about their habit history. Now, looking at those lesions, especially angle of the lip, which often get masked with the mouth mirror, ventral surface of the tongue, which we don't really look into it, the lateral surface of the tongue. And what do we do when we see these lesions? The three critical part, which Moni sir also did mention, is sight, size, and color. So these are the three clinical data which we would like to capture when we see a patient, just to put them as high risk or low risk, no invasive procedure, just by clinical examination. And maybe if you have a good imaging, documenting those with the photographs. So this is what the clinical risk profiling is, which we look at whether it's homogeneous or non-homogeneous, less than 2 centimeters or more than 2 centimeters, and the site. And if you look at India, you find a lot of buccogingival carcinomas, but the potential sites for malignant transformation is the lateral border of the tongue and the floor of the mouth. So this is what we thought of capturing. And as you understand, oral cancer is a disease of a lower economic strata. The patient don't report most often. So we thought it is high time that we go and reach them rather than waiting for them to come. And then these were the two approaches. One was the opportunistic screening with a dental college, or go to a primary healthcare and use the outreach program, making use of the healthcare workers. And we looked at the technology, how a technology can empower our approach. So this is a simple mobile application which we developed about 10 years back. It's nearly a decade of it. A data capture of image and the risk factors, connecting to a specialist to triage the patient. Now, the first paper which came out of this pilot study in JADA very clearly stated that technology is robust, it works, but what needs is to empower the healthcare workers with more diagnostics or to improve the diagnostic accuracy. So what happened next is, and of course, with the experience, we did understand that we have to integrate with the general health to encourage for more participants to flow into a screening. So measurement of their blood pressure or blood sugar level always encourage more participants, because they found more value rather than just getting the oral examination done. And along with that, we try to capture those three important clinical features, which to put them as low risk or high risk, especially in an outreach program. So this is a simple mobile application which has a drop down and captures images. And look at these images, how much of information. It's an indurating lesion. This is a surface ulceration, probably just because of more usage of lime. This is a squamous papilloma, absolute no tobacco stain, proliferative lesions, traumatic ulcer. Look at the necrotic base. So these images were giving us so much of information, which we could give it back to the patients who are there at home to tell whether it's important or not important to move for the next level of care and when they should do it. And of course, it has a dashboard which gives the appointments and takes for surveillance. And you have a lot of analytics to do with the data which comes in normal, how many have difficulty, how many have lesions with how many have with habits have developed the lesions. So there's a lot you can play with the data which is captured. And this is where we stand, more than 60,000 screened. This is the parts of India which we have both primary and secondary prevention, either conducted or ongoing. Now, what's important at this stage of, I would like to tell is, these numbers are not making any more significance for us. The more significance is how do we follow up these cases? The follow-up is a very big challenge for us, especially as an outreach. And then one paper which came on IJC, which was very encouraging, is the sensitivity between a healthcare worker and a remote diagnosis was about 75.2. So which indicates that we can go for a scale up. And accuracy between on-site and a remote specialist. Remote specialist is the one who sits behind and sees the back-end data. And on-site is whenever we have a chance, we put an on-site specialist. So they look at the concordance, so that on-site and remote specialist concordance is very good. And healthcare worker and remote is about 75. It's not bad, and as an outreach program at a community level. So with this, we looked at what do we do next? Now we need to develop some devices which can be used by a low-skill personnel that essentially have a healthcare worker, which has to be non-invasive. It has to be a low cost because it's a scale-up program. And we need, more importantly, is the follow-up of the cases. It's not the diagnosis. Diagnosis is working. Cross-sectionally, we are doing well. But we need something which to see and objectively assess whether this patient is progressing or not. Now I'll tell you the importance of a low-skill personnel. There are two ways which we understand in a primary healthcare. If a primary healthcare has a heavy footfall of the patients, the doctors are extremely busy. They don't have time to do an additional work. And if the primary healthcare has no footfall, then the response for the program also is not going to be encouraging. So the way to approach is use the healthcare worker and enhance their skills. And these healthcare workers are good enablers because they will exactly follow the protocol. They won't use much of their brains, and they'll do step after the step as suggested. So with this idea, we went into the clinical adjuncts, as mentioned by Dr. Pogrel. The vital staining is still a best clinical adjunct. The Cochrane database systematic review meta-analysis gives you about 84% of sensitivity and specificity of 70%. Now, this is the baseline for any technologies devices which comes. And we thought, let's try to match near that and see if it's going to work. Now, the next important thing which we realized in our approach is we cannot have the patient referral up. It cannot work. Referral up works when the lesion or a condition is symptomatic and when patient seeks help. And when you're trying to downstage and we are trying to educate and motivate, it should be a referral down. So we need to get more and more diagnostic going at a granular level rather than asking the patient to move to an upper level for their care or for the treatment. So the diagnostics which we worked now and we are at this stage is, of course, the mobile health, which has a good sensitivity. And the next 4 factors which I'm going to speak in the next 5 minutes. One is autofluorescence imaging. One is a cell scope. It's a telemicroscopy. And 2 molecular markers, lectin and PARP, and optical coherence tomography. Now, if you look at the stage we are in, most of them are clinically validated, have a very good high index publications, proved their worth, but implementation is taking its own time. Now, this year has gone. This year, we hardly have done much work because of the pandemic. And the first thing which has really rolled out to the next level is the autofluorescence imaging attached to a mobile phone. Now, these are the 3 devices which I would like to discuss in the next few slides. This is the mobile phone which comes with an autofluorescence, the well scope, which the earlier speaker spoke about. And there's the cell scope and there's the optical coherence tomography. Now, how do we position this? Now, if you look at these devices, the device's accuracy goes up as they go higher in the healthcare. Now, autofluorescence imaging is a very simple triaging of telling yes or no. It just says whether lesion is suspicious or non-suspicious. While if you do a cytology, it has more level of accuracy. With the markers, the accuracy increases, and optical coherence tomography is also a very good diagnostic. And do remember, the cost also increases of all these devices as the accuracy levels increases. So I'll just go into our approach of this autofluorescence imaging. So when you click it, it gives you a white light image as regular as your phone camera. And this is the fluorescent images, which goes in one click. It was through an NIH grant. And we tried it in the worst or the really poor low resource setting, including Nagaland. Nagaland, I don't know how many of you need work permit to go to that state. So, but this is what our test was, to see one of the really challenging condition, whether it works. So it involved a lot of community people involvement. It involved integration of their regular healthcare, and get their peers as a part of the program, education and motivation in a subgroups, so that the whole village gets involved. And the healthcare worker was given a kit. He looked like a doctor when he walked into the field. And this is how the images were captured from the patients. And wherever they were in this study, the two places, Bangalore and Dimapur, which we have done, there were an on-site specialist wherever we could do it. There was a tertiary center, there was a nodal center, and an outreach program. And all the patients' images were uploaded to a remote specialist, which was de-identified. And the three outputs, that is healthcare diagnosis, on-site diagnosis, remote diagnosis, were compared whenever possible with an histopathology. And of course, the imaging included white light as well as autofluorescence. So just before the pandemic broke in March, within 5 months, we captured about 7,000 more than images. And we have restarted again in this November. The program has started again. And I'm going to tell you a few data about the 7,000 images we have captured. This is how the images are obtained. This is your regular camera. This is autofluorescence imaging. And this is from the probe, which captures a closed image of the lesions. And this is another one which clearly demarcates. If the resolution is good, you can appreciate the fluorescent imaging. And a few more examples of how this imaging has been done by using a mobile phone. This is submucous fibrosis, intense glowing of hyper-intense areas of the fibrosed areas. And at this is an unpublished data. Where we stand is, if you use this artificial intelligence, which has been incorporated into these images, we are able to differentiate normal suspicious about 86%. So this sensitivity we have achieved at, the study is still ongoing on. We have 86% just to tell yes or no. So what does this do? This does that the patient is telling the patient whether they have to move to the next level of care or they're fine at home. So this is a tool which can be used at door to door. No more diagnostics, just to say whether the patient is suspicious of a lesion or not a suspicious of a lesion. I'll go to take next 5 minutes for the other few things which I quickly run through. One is the telemicroscopy or a cell scope. This is a cytology based one. So you do the scrapings, and then it has a convolutional neural network. We have a good sensitivity of this, about 70%. So this can be done with a nurse or an health auxiliary, and probably you need a primary healthcare for that. And as you notice, the advanced lesions, you have a good accuracy. The challenge is to differentiate benign and the precancerous lesions. And then the other one, the molecular marker is known as lectin. That is a wheat germ agglutinin, that is WGA, which is attached with the fluoroscopes. And it looks at an aberrant glycosylation of the cell membrane. And then when you apply on that, that's how the dysplastic cells fluorosis. So this has, again, a good sensitivity for an advanced lesion, and for a moderate dysplasia, or when you come to a benign and malignant, the sensitivity keeps dropping. The other one is the PARP. Now, PARP is a DNA repair enzyme. So it looks at the DNA strands break. It's a quantitative biomarker developed from Memorial Sloan. So this is added along with it. So what we are ideally looking at is multimodal approach. So you combine everything, then maybe you will have a good accuracy, about 80–85%. All non-invasive, can be used by a low-skill person. automated with an artificial intelligence, giving an objective scores, probably understanding the progression of the lesions. So the last one I would like to do is an optical coherence tomography. This is the prototype of a lesion. And that looks at the epithelium and the connective tissue. And so this study was compared with the image analysis and histopathology. And this how it appears. So if it's a squamous cell carcinoma, there's no pattern. Then you have a disruption, a severe dysplasia or a mild dysplasia will have a straight line. Now, this also is enabled with an AI tool. So you get the alpha values. These alpha values will give you some idea of where the lesions is when the patients are followed for a longer time. And then it's a good, I mean, if you're an oncosurgeon or a maxillofacial surgeon, there's a good tumor margin study done with that to understand whether your margin is safe or not. You can look at a paper on oral oncology, a good sensitivity of 88.89 and specificity of 66%. Now, all these done in a small sample sizes in a control setting. Only the autofluorescence has gone to the field. The rest we are waiting at one stage to go to the field and enhance and look at the utility and the feasibility of doing this. And you do have to understand that the scores which comes has its own limitations. Of supposing if it's an optical coherence tomography, if imaging an aphthous ulcer when there is no epithelium, it might interpret as a malignancy because it needs an epithelium to understand and differentiate between the connective tissue. So the final goal which we are really looking is when we get these patients, we need to triage them, get the devices which suits to the different level of healthcare, and a very big ambitious plan of following those patients for a period of time of all these and see how accurate they are. So this is where it needs when you're looking at a linkage to care, it has to be very comprehensive. The most important is the surveillance, which we are very keen on to do it in our upcoming programs. Now, the next one, during the pandemic, what we have started now is in the Varanasi. So it's totally a different approach. The household enumeration has been done. Once they're done, then there is a telephonic triaging and screening is by appointment. So the patients are called to the primary healthcare on an appointment to get themselves screened. And this is where we are at yesterday. So the household enumeration has been done. Probably by December, I think the data should start flowing and probably help us how do we screen in a pandemic and with the necessary precautions. Of course, the numbers are going to be very, very low, but understand at least we have given some start. And I'm just speaking here. I don't know how many people I should thank for this. It's a collaborative approach from Mazumdar Shaw Translational Research, Cancer Center, Biocon Foundation, and all the funding from technology from the lot of US universities, and of course the outreach primary healthcare centers and KLE for their acting as a nodal center. So it's just too many people. And of course, it's under Oral Cancer Task Force led by Kiran Mazumdar-Shaw, Dr. Rath, Moni sir, Pankaj sir, and many more on that. And the right side, you see the other key partners which have been significantly, Amrita Samsam, Principal, Shiva Saji, Sanjana, and my colleagues at KLE who have been tirelessly working to achieve what we have done so far in last 10 years. And this thank note is only about Indians. There are so many healthcare workers who have helped, and of course our international collaborators. Thank you very much. I think I'm on time, and please feel free to write to me. And I end my talk here.
Thank you, Dr. Praveen. That was a very, very interesting lecture and very insightful as well. The technology is not so well known through this lecture. We have really been made aware of something very good that we are doing for the society. We would like to now welcome our next speaker, Dr. Neera Trivedi, who is from Gujarat, a very well-known head and neck cancer surgeon trained in general surgery since 14 years. Welcome, Dr. Neera. It's a pleasure to have you.
Thank you very much. And I just again want to thank AOMSI for giving me this opportunity. Now, I'm going to speak about pre-screening. I'll first, have a small presentation. Can you all see the slides? Okay.
Yes,
So
clear.
we have been listening to cancer screening approaches by eminent speakers all throughout this evening, and I want to highlight certain points that we face on day-to-day basis in implementing cancer screening at a global level or at a national level. So if we look at screening, we can divide into two steps. One is to identify high risk individuals from the entire community. And step two is from those high risk individuals who needs treatment or who needs observation. So these are for me basic two steps of the entire screening process. Now in conventional screening, most of the time what we do is we try to do both the steps together. Now there are certain limitations of this approach. Number one is that you need to have a physical contact with the person. You cannot do this screening without meeting a person. Number two is that you need to have at least some type of trained personnel when he meets a patient or a person to examine them. Now, second limitation is that it needs to be repeated every few months interval, because if you examine a patient now, there is no guarantee that he will not develop a lesion in 1 week time or a 1 month time or a 3 month time. So ideal screening process needs to be repeated at periodic intervals. Now, can you imagine we have about 1.4 billion people in India with a diverse environment, and you consider across globe, it's a huge population burden. So this, for me, conventional approach is not feasible nor sustainable. Now, it's not cost effective as well. And that's the reason why none of the developing countries have a successful screening program running. Now, what is our concept? So we want to introduce a process called pre-screening, where the step one, identifying high-risk individual from a global community or a community as a large, should be done by a non-contact method. And then as a step two, identified high-risk individual should be traced, and then only those should be subjected for a contact screening. What is the advantage? So you only have to physically come in contact with people whom you have already pre-screened to be high-risk individual. So that's the concept of pre-screening that I want to introduce, and I want to say how we can do it. So ours is a simple digital initiative. So we have developed a mobile application that allows person to self-screen. It's very easy to use for laymen. As of now, it's in Hindi, English, and Gujarati, but you can convert it to any local language as you want. You don't need any physical contact. It can be done by a mobile within 15 to 30 minutes. You can repeat it and use it every few months. High risk individuals, so they self score, and I will demonstrate that live onto the website. They can self score, and the people with high risk scores can be filtered from the admin grid, so that when you have their contact number, so you can contact them and guide them to go to a nearest dentist or a medical officer or a government health center. uh, One of the most important aspect of this, which in my opinion is very underrated in the concept of screening, is patient education. Now it's practically impossible for you to continuously come in contact with the patient and keep looking at at their mouth or their cervix or their breast to identify a lesion. So most important thing is if you can make people aware about signs and symptoms of cancer so that you can detect them early. So rather than me looking at their mouth and say you may have a white patch or a red patch, it's better for them to actually understand that what is the significance of white patch, what is the significance of red patch, so that when they come into contact with that, uh, they can directly contact a healthcare worker and say, just look at my mouth and do I have any problem? So for me, this initiative, if they self screen, they become aware about screening their own self, and then they can contact. So this probably will be one of the most important side benefit of doing this pre-screening through self-screening methods. Now another thing, why should we only look at oral cancer in isolation? Because if you are going to connect a person, it's also very, very important that you should screen all the common cancers that are screenable. So that again can be achieved through this program. Now, before I move on to the application demonstration, how we can implement at a mass level. You can directly actually reach the people. If you have a funding, you can run a media drive in a particular region with the support of some NGO, and then people can just download it on their mobile, and then they self screen it, and we at the central office we can guide them to go to meet a local doctor. All the doctors can use this program in the clinic. Patient and relatives are waiting in the clinic, so dentists and all, they can have a banner onto their clinic, and all the people there, the receptionist can say that why don't you log in and self screen. And that's another way of doing it. And then if the government gets interested, then we can use this in a district program first, to train your PHC ASHA workers who go onto the field. So this is like a self train. They just log in and watch the videos and then do the self screen. They will already learn how to do the screening, and then they can, if they have the mobile phone, they can go in the field and actually screen people. Or otherwise, if they don't want to use the app, at least they know how to screen, and they can identify the high risk people and then bring back to the PHC where doctor can use the app and screen them. So this is how we can use this application. Now let's see the application live. And I really hope that AOMSI or dental community can be partner to this program, and we can do some pilots. I'll just for a moment stop sharing the screen and go to another screen where I can show the application live. Okay, so I hope you can see. So that's oncodigital.com. That's our application. And now I will show you. When you go down, this application also helps cancer patients go through their entire treatment. So if you are a cancer patient, you can actually register for a self-help website. And if you are a normal person, you can register for a self-screening. All the steps are self-explanatory. There's also a video where they tell you how to do this self-screening so that it's self-explanatory. If you go to register, just basic your mobile number and all that, and you can do that. One of the important things is you can actually go all the way country, state, district, and city, so that when you look at the admin screen, all this data will be there, so you can easily refer the patients where they can go to a local health center or something. I'll just take a pre-registered patient and I'll just log in. So we can directly go to the sign. They can go to form. So this is, you can see there's a language options, and for everybody to understand, I'll select an English language. There is cancer screening. They put this up, and this works on mobile. As of now, it's not in an application form, but you just go www.oncodigital.com on your Google Chrome or something, and you follow all the steps that I am sharing. It's self-explanatory that what are the steps that you need to do. So you watch video, answer questions, all the things is self-explanatory. So first step, they will watch the video. There is an instruction here, and when they go to the video, I don't know why. So there are various videos about mouth self-examination, breast self-examination, overall male screening, female screening, everything is there. So they can watch this video and they will understand the entire process. Once they watch this video, they say, okay, I have watched the video, and save. So then they go to the next. So this becomes complete. Then they go to hereditary risk factors, where is anyone in your family have cancer, blah, blah, blah. So all those things. So whatever answer they will give, they will suggest your score, and then they will suggest you what is the next step. What are the things that you have to do. So it's also telling you, it's guiding you basically to when to approach. It's like a proper self-explanatory thing. I'll just complete whatever, and then we go move forward. Same way, then you go to substance addiction, and they'll ask you various questions. Do you have this or no? If you say yes, again your score is there, and then they will tell you life modification and all those things. Then comes to the lifestyle related risk factor. You have obesity or blah blah blah. You say no, your score is 0. So you go forward again. Then this is an important bit. This is like a cancer specific sign. So we have included all the cancers with their common signs and symptoms. So we just answer one by one. So weight loss and all, if say yes, that means, they will guide you further. So if a voice box cancer, they will ask you to go to an ENT surgeon. They may advise a scopy and get a CT scan if required. So they have a fair idea about what next will come, like esophagus, and they will tell you whatever. Oral cancer, no. So, or if yes, they'll tell you exactly what are the things, explain whatever our previous speakers has been telling them. So for sake of completion, I'll say colorectal cancer, prostate cancer, breast cancer, whatever you common cancers that can present with a sign and symptom will come here, lung cancer, blood cancer, whatever you say, and then you submit. So this way on a single go, most of the things can be done. Then there are self-examination, videos, how you do that and all those things. Um, I'm just sorry, I'll just complete that. So this encourages them to do self-examination, encourages them from the videos they learn, and they do their self-examination. Then there are yearly screening tests. So there are certain enthusiastic or educated people who would also like to get some basic screening investigations done. So this guides them about what are the investigations that they can done. So, these are the people who should get the screening done. So say, okay, I am age above 40. I may have a family history. So if anything of this is there, then I may go ahead and get certain tests done. So I can get CBC done, and it will also tell me what are the reports like that. So if I'm male above 40, I may get my PSA done. What is the significance of this test? X-ray chest, sonography of abdomen. These are all optional. They are not based on any guidelines, but they are based on common sense, based on your common clinical practice. Mammography, if you do, what is the Bired's grading is also given, and you can say, okay, the report says Bired's 3. What is the significance of 3 is probably benign. So it's like a self-educatory tool. They don't need to even go to a doctor. PEPS test, school and occult test, when to be done, what is the significance of them, colonoscopy if it is to be done, and these all the things are self-explained in videos. So it's very very easy if they follow the system. When they come here, they will already know what is to be done. Then based on whatever they have answered, they can self-score. So, this is explaining if your score is 0, 1, when it is to be done. So they can, after reading this proper sentence, they can say, okay, if the score is 0, that means neither you have any hereditary or substance abuse risk factor, nor you have any signs present, nor your any of the investigations are abnormal. So you can score yourself 0 and you are fine. It's 1, 2, 3 means you have some, like a hereditary risk factor, or you have substance abuse or some lifestyle related risk factors. So this 1, 2, 3 means your lifestyle modification is required. And if 4 to 7 means you have one of the signs positive or one of the investigations positive. So whatever score you apply here, then if based on this, if you have gone and contacted a doctor, you can also say what your doctor's opinion was and say maybe pre-cancer. And if you got any investigations and any of the investigations were normal, if all or someone was abnormal, you put that and then you save them. Once you save them, you can see the entire summary will come here. They can take a PDF of this entire summary from here and they can save it. They can share it with any of your doctors. And at the same time, the scoring, what they gave, would actually, this score will go, these three things will go on to the admin grid. So every day, if I have one person sitting at the admin and all today's new screen patient, if they put a filter to score 4 to 7 within a second, they can get, okay, out of 2000 screen today, there were 50 which had score 4 to 7. So that person task next day morning is to contact those 50 people, just check why the score was 4 to 7, or even he can look at this report and say, okay, you have this, maybe you should go and contact a doctor. So without actually going into the field, without meeting any people, if we can use media or the health worker or all clinicians spread into the community to use this application, we can identify high risk people, not only for oral cancer, or for all common cancers. And these patients should be contacted with various means, and then they can actually be subjected to this. We are also working on regular notifications. So once you have registered, every 3 or 6 months, based on what we decide, you will get a notification on your app that you need to re-screen yourself if you have developed anything particularly. So once they go through this entire education exercise, they know that I am smoking or I am chewing tobacco, or my mother had a breast cancer, so I should be regularly screening. So based on that notification, particularly for 1 to 3 or 4 to 7 group, they will come back and rescreen. So we have a data of about 5,000 patients, and this works in all strata. For poor people, we have gone through ASHA workers, where they have screened and they put the data here. And for educated people or people waiting in the clinics and all, they have been self screening, and they have been, the feedbacks have been very, very encouraging. So this was a brief about how you can use this digital mobile application for pre-screening, and I'll be really happy to have all the questions either now or during the panel discussion. That's all. Thank you very much.
Thank you so much, Dr. Neerav. The presentation was very good, and I think in a country like India, we certainly need something like this at a community level. Let's now understand how that can be done through the panel discussion. Dr. Shubhra, do we have questions?
Yeah, maybe we'll start with the simple one. One of the questions was, does sharp tooth cause an ulcer or leads to malignancy? We are quite sure about the answer is yes, but we'll take it with the Dr. Moni. So, what do you think? Like a sharp tooth causing an ulcer, how long do we wait for it for doing a biopsy, and how do we go about treating it? Like there are a lot of people who think that we should go in directly for a removal of the tooth or blunting of the. So what is your call on it?
So if there is a irritant causing a trauma, that needs to be removed. That is the first thing to do. If you're removing, adjusting the sharp tooth or clasp or whatever, that can be done. And then see whether the lesion responds. Most of the time, the lesion will respond within the 2 weeks' time. If it responds, that's good. If not, then of course, Dr. Pogrel mentioned about 2 weeks' time or 2 or 3 weeks' time. There they need to.
Thank you. So we can the removal should be the primary importance, and we wait the same principle we use of waiting of 2 weeks, right, sir? Yes, ma'am. You can go.
So, as far as the sharp tooth is concerned, would you like to also consider the presence of underlying risk factors in these patients? Patients with underlying risk factors having a sharp tooth are more likely to convert an ulcer into a malignancy. Would you like to say that? Dr. Pogrel can also contribute.
Yeah, definitely, yes. Yeah, because most of the time it's not just single risk factors. There will be tobacco, alcohol will be there. Sharp tooth may be one of the additional risk factors. So, but once you find a risk factor, once you find a sharp tooth, correct it. Alcoholism, getting rid of maybe take time. Smoking, stopping will take time. So the traumatic cause corrected, and of course then habituation needs to be taken up along with it.
What we understand is that sharp tooth is definitely a risk factor for the ulcer, which is formed and needs a right attention at the time, at a proper time, as soon as it is noticed. So I guess that also emphasizes the role of a dental surgeon in observing, right? So many times when patient comes to us with a different complaint, and sharp tooth is actually not the complaint, but it's a dental surgeon who, when she observes it, that she can bring it to patient's attention. I think that's a very good point. Now, the next question is, uh, Dr. Praveen and Dr. Neerav, we heard a lot about the use of technology, but in a country like India, where there's a lot of illiteracy, and a lot of us, our parents, especially we have seen in the rural sector, they have mobile phones because they can buy it, but they don't read much. They cannot read. So, in such a case scenario, in the rural sector, how do we overcome this problem, particularly if we want to use this technology? I guess that's where the healthcare workers will come into picture.
Raveen, you go ahead.
Yeah. So that's true, because even when a remote specialist sends a recommendation, it needs some sort of an interpretation. So a layman and will have difficulty to understand what it is. So this essentially goes during our training program. How do you convey and what do you convey? So the healthcare workers are very, very critical. That's why in our approach, we always kept at least some sort of trained person in between the data and the interpret and the conveying the factors. So healthcare workers are important, and the region we have worked is very rural, very, very rural India. So we have not dared to go into a direct conversation with the patients. And of course, the final goal, which we do look at it, is if our AI works really well, so they should be able to capture an image, and that image should, at the point of care, should tell what is the status of the lesion. So that will take some time. But as of now, the healthcare workers are the very, very important and key person in this screening program. Neerav?
Yeah, I completely agree with Praveen that, there are, when you look at the ground reality, there are two type of patient. One group is, educated, or I would say motivated to use this kind of technology, the mobile phone, for the right kind of purpose, like, health and all that. And those people can really do it themselves. But there is a group of people who, either because they don't know, or they don't have, or they are not so much enthusiastic about using it for the health, and those are the people that needs to be touched by healthcare worker. And you need to have a system where, like what very elegantly Praveen and Moni sir and all trying to do, is how you integrate them into an entire system in a seamless way. So I think both of them are important.
Right, sir. So coming to Dr. Tony, so what is your call on taking biopsy? You did mention about the ways and about the use of many equipments for doing the biopsy for pre-malignant lesions. But what is your call on taking biopsy for these? Do we go in for biopsy for all pre-malignant lesions? Or do you have a clinical picture that for these lesions we will do, these lesions we will avoid and wait and observe? And in case we wait and observe, what is your time limit we should wait for re-reviewing the patient to again make the judgment?
Yeah, I mean, we biopsy all these lesions initially because you do want to know what they are. But once you know what they are, you can then decide how you're going to manage them. And for the mild dysplasias, we will often observe them, but that does need a cooperative patient. We need to know they're going to come back every 6 or 9 months and that they're going to let us know if anything changes. They have to monitor it themselves and call us if it changes. And if we feel they can meet those criteria, we are quite prepared to just observe them. If it's a moderate dysplasia or severe dysplasia, we're much more likely to want to remove it. But the problem is some of them are quite extensive and it's almost impossible to remove some of them. And even if you can, if you have to put a skin graft on or a dermal graft,
Yes, sir.
there's morbidity attached to that. They're never quite the same again.
Yes.
I'm just noticing that by my name at the bottom there, it's got the pronouns to use. This is something new that our university has done in the last month, that I have to identify my gender, not my sex, but my gender, how I interpret myself, and then what pronouns I want used to describe me. So I see it's done it for me. I am he, him, and his, and I am very grateful for that. So it's
Right.
a sign of the times.
Right, sir. Thank you. Moni, sir, you showed us a picture where you had a cancer in one particular area, like the tuberosity, and alongside you had a pre-malignant lesions. So when such a patient primarily lands up in our OPD, do you think the frank cancer is pretty obvious? Of course, we have to take a biopsy to prove it to do the treatment. But do you think we should take a separate biopsy from the pre-malignant area at the same time? One, sir. And second thing, when we go in for treatment of this patient, how do you take the margin for him when you're doing the treatment of the primary along with the lesion in continuity or for a pre-malignant lesion?
Thanks, Shubhra. This is a very common problem we see in our part of the world.
Yes, sir.
Cancer associated with the potentially malignant lesion all around. Okay, so we do only biopsy of the primary lesion. Now, let us say on the contralateral side, some other area not adjacent to the lesion has got some lesion, then that needs to be biopsied and characterized, because that needs to be separately treated. This particular tumor needs to be treated, okay, excised, so that will be staged by scans and so on. Now, whenever there is there's a oral potentially malignant lesion and then a tumor associated with that, the margin has to be really, really wide, okay, because it's very difficult to get a dysplasia-free margin, but still we try to get as wide margin as possible, not just 1 centimeter, 2 maybe 2.5, 3 centimeters required that you do that, but the depth can be shallow. Around the potentially malignant lesion, you take a shallow margin. Of the malignant area, you take as if you are doing a cancer resection.
And sir, do you feel that frozen section for diagnosing a pre-malignant is good enough as histopath, or it's better to do the biopsy before we go into the OT?
No frozen section. I wish Pankaj was here to answer this question. Dr. Pankaj has done a study of 160 odd patients, and he has shown very clearly that if you resect the tumor and the gross margin, gross mucosa all around is more than 7 millimeters, there is no addition of doing frozen section. Relying on frozen section to get a negative margin is not a good surgical practice. So we will do frozen section, let us say the septum of the tongue, where the contralateral lingual artery can be an issue. To preserve that, we might do frozen section, but frozen section on the whole, we don't do it very often. I'm sure Dr. Pogre will have different thoughts of and so on, but that is the commonsensical approach we practice.
Dr. Tony, how about you, sir? How often is the role of frozen section in your OT?
In pre-malignant
Sorry, I
lesions.
wasn't concentrating, Moni. I missed the question.
No, sir. How often do you use frozen section in your operations?
In the definitive surgery, virtually all the time. In the outpatient clinic, very, very rarely. Our oral pathologists, in fact, do not like frozen sections. Our general pathologists do. So when we're in the main operating room, we use frozen sections, but in the clinic, we do not.
Right, sir.
Dr. Tony, there are two questions for you. There's somebody who wants to know about role of fungus and antifungals in the pre-malignant lesions. And also there is an interesting concept of HPV vaccine, how significant it is in the role of prevention of oral cancer, HPV vaccine. Can you please comment on this, please?
Fungus, we will often grow candida from our lesions, and it's mainly candida that we find. We often grow actino as well, actinomycosis, and these are often confounding variables. And we do give them antifungal treatment. We do give them antibiotic treatment. It does clear up the fungus. It does show you what the underlying lesion probably is. But there's still the question of, is it etiological? Is it a cause, or is it just a secondary contaminant? And our feeling at the moment is it's a secondary contaminant. The trouble with Candida is that the patient often has an underlying immunodeficiency of some kind, and that's why they predispose to candidal infection. So we do know that patients who get Candida are actually more liable to develop oral cancer, but it's probably not the Candida that causes it. It's the fact that they are probably immunodeficient in some way, and we can't always diagnose that. Yes, the issue of HPV vaccination is a fascinating one. We have just mandated here that male children aged 12 must be vaccinated for HPV as well as females, because obviously originally it was for cervical cancer in females. Now we're realizing that it may also work for not oral cancer as much as oropharyngeal cancer. It probably doesn't have much effect on oral cancer, but it probably does have an effect on oropharyngeal cancer. The problem is this has only just started, at least in the United States, in the last couple of years to vaccinate the males as well as the females. And we'll have to wait, 10, 15, 20 years to find out whether it's actually effective. Because a 12-year-old is not going to develop oral cancer until they're much older. So to know whether it's preventive or not, we don't know. But the idea is there. And yes, it is now being recommended that 12-year-old males should receive the vaccine as well as females.
So until then, I think we have a lot of other things to cover up, like taking care of our habits and other risk factors before we reach the HPV and the vaccine. In India, we have so many other causes which can contribute higher incidence.
Dr. Neerav, there is a question about the app you have been using. What about the consent for the app the patient is using and protection of the data which is coming to the app, sir? And how many people have access, the admin access? Like suppose you're telling that we can promote the app through clinics, we can promote the app through NGOs. So how much access do those people have, and who actually has the final access to it? So consent and privacy about the data.
There is a kind of a proper consent before you sign in. You always say I agree to terms and condition, and then there is a proper signing that this is an educative thing, and we do that. Second, this is like a self-reported outcome. So there is not like a proper health records or anything that's like medico-legally, a kind of a binding. There are no reports uploaded or not scanned or anything. It's just like a survey which you're willingly given to that. The access of the admin is only to our, as of now, only to our core team, and we try to keep it that way, not giving to any NGOs or anybody, but it's going to remain with us. This entire app is properly based on your HIPAA laws and all that, so that as of now, what are the current standards in telemedicine or the telehealth, we are following that.
Right. Thank you, sir. Praveen, sir, there was a how, like you said, we can go in for community screening and all that. Now the primary, many times what happens is these screenings fail due to the lack of input from the crowd. Like there's less input into the camp which is put up. So do you do a lot of this priming before putting the actual camp, like an NGO worker or healthcare worker announcing, priming the people about the importance of screening, something like that? How do you go about it, or you just directly announce and put the camp? Because that problem is faced by a lot of us actually trying to do a camp.
Yeah, that's a real challenge. So if you look at it, there are two ways to approach. One is door to door. So that's very intense. Okay. And the best enabler is the ASHA worker, because he knows each household, he knows he or she knows, generally females, they know who smoke, who don't smoke, in the which house, what is the how many people are there. So there we essentially use the panchayats, the village heads, and have a general talk. And if you arrange for a talk, the participant will be less. The people are, because especially when you're talking about tobacco, they know that it is harmful and they don't participate. But with the due permission, these ashas have very good skills to go and meet them and reach them out. And the key thing is, what do they get out of it after screening? So we have discussed with Monis a lot of times. So we just give an vitamin A local application. It's 30 capsules will cost about 24 rupees. And this is some sort of an incentive. If you go by the level of evidence, it's not a great chemotherapeutic agent. But what I understand is it does two things. When the patient applies on the lesion, especially if it's a smokeless, he understands what it is. And his self-examination and awareness increases. So that's the way the participation for the screening increases, because you have to do something and you have to integrate maybe a diabetes health camp or a blood pressure. Now, if you're doing we did through street sanitizers in Bangalore. So that went through an Bangalore Corporation unit. So in such a case, there is an order issued that everybody has to get screened. So there, it's more like a factory setting or a workplace setting where everybody does. But to walk into any place and do a camp, or even you do a camp, Shubhra, what we are really looking is, we don't want them to just see and leave them. We want them to follow for a longer time. So in that way, we need a lot of engagement with them. It's not that one cross-sectional type of an screening to be done. So to improve the screening, participation of screening, the house-to-house is the best one, but it is very intense, time-consuming. If you're trying to do a camp-based, maybe you have to go through a proper organization and then make an awareness. Or at times it gets integrated with other camps and then you do it. But I don't see much value in it, because we don't want them to fetch on their own after that. We want them to be followed for a longer time. I think the more important is to engage the local partners as much as possible, have a buy-in, and find some value for those people who walk in for screening.
Actually, there was a question exactly on the vitamin A, retinoids use.
Yeah.
So maybe you and Dr. Tony can take it. Use of retinoid and how effective they are for pre-malignant lesions. Exactly the same question. So
in fact, I just wanted to add something, Dr. Praveen and Dr. Neerav. There's this very beautiful documentary on Netflix at the moment running, Bending the Arc. It talks about partners in health, and this whole concept of how the community health can be awakened but the workers act as an accompaniment system where they just go and identify or reinforce. Like, for example, there's a tobacco addiction. So the de-addiction part has to be reinforced by the workers constantly by staying in touch. But as far as the treatment and examination part is concerned, they have to consult the specialist. They have to be seen by the right people, the doctors per se. So I think that's, especially in your paper also, Dr. Praveen, I read that the number of people who turn up for biopsy through long distance ASHA workers, the biopsy rate is much lower as compared to the one cohort 2, in which the patients are directly seeing the specialist, right? That's what the paper says.
Yes. I mean, the transformation to biopsies is a huge challenge in a community. They are asymptomatic. They have examples of forefather, grandfather who lived happily chewing tobacco. So it's not easy. So the transformation of biopsies is always a big challenge. That's why we are looking at some non-invasive way to identify the lesions and then monitor it. So so biopsy is always a challenge.
But they agree better if there is a specialist around. I think they agree more easily.
How do we get a specialist all the time? That's why we are using a remote specialist. So there is some level of understanding, and it has a good accuracy with an on-site specialist. So the technology works. And this is how it slightly differs from Ayushman Bharat also. If you look at Ayushman Bharat, where they're doing the screening, it's a referral up. which doesn't work. The medical officer is extremely busy. He will just say something, and patient won't move. Loss of wage, cost, travel, a lot of things will come into it. So we are looking the other way around and see if it's going to work. But we need some more time to really establish this proof of concept.
So now for the treatment part, I think all of one by one we can take Dr. Tony, Dr. Moni, and Praveen. What about retinoids and other treatment for pre-melanin? Other than we got the point that moderate and high grade is other suspicious when we go for excision. But what about the other lesions? What in your practice is followed, like using vitamin A application or multivitamins? What is the treatment plan you're taking in for the pre-malignant lesions?
Well, if I can answer that first, retinoids themselves, we have not used for about 15 years, mainly because of the thinning of the mucosa that it causes and the cracking of the mucosa. But that's the rationale for using carotenoids, because retinoids are essentially vitamin A, and that's an animal product, whereas the carotenoids or beta carotene is the plant version of vitamin A. So that is what we're using in the form of carrot juice or carrots or whatever form the patient wants to take beta carotene. And even that is controversial. There are many people who say beta carotene really doesn't have any preventive action, but we do recommend it. So we are in fact using the equivalent of the retinoids, but in a way that doesn't cause the side effects.
So how long are you using carotenoids, sir? What is the duration?
Oh, they can take them forever. I mean, they love that. The one that I showed you, the Adwala carrot juice, which has 400% of the recommended daily dose of vitamin A. So you're getting a large dose. They'll take that every morning as a drink. And some people take it just because they want to feel healthy. Some people take it because they've had oral cancer and they want to know what to do to prevent it coming back again. And they don't like being told negative things. Don't do this, don't do that. They want positive things, do this. So they'd much rather be told, have a drink of carrot juice every day, or tomato juice for that matter, has quite high beta carotene levels. There are a number of vegetables that do, but we usually recommend carrot juice. So yeah, they take it every day, and relatives do as well. You know, if a spouse has had oral cancer, you will find that the spouse will often drink the carrot juice as well, because they've seen what it's like to have oral cancer and they don't want to get it.
Dr. Moni, any
I think we're great advertisers for Odwalla carrot juice, actually.
Indeed.
Yeah, I think what we see, first of all, there are no effective chemopreventive agents. Okay?
Yes, sir.
Yeah, I totally agree with Dr. Praveen that we do give a lot topical vitamin A. It does work. Okay, there is no question about that. But the problem is that the moment you stop using it, the lesion comes back. So we use this as a like a, you know, a carrot and stick kind of thing. So then you have to give something, and then so that they will come off the habit and so on. So they just. But what is proven to be most effective is our own publication about that curcumin trial showed that in 67% of the patients it works, and those patients with the response, it's a durable response. Unlike the chemopreventive agents, it does retain this clinical response.
There was a specific question about a case of a granular cell tumor on the tongue, dorsum tongue, around 1.5 into 1.5 centimeters, which were finally turned out to be with margin involved and ATP are present. So the doctor is asking about the treatment plan and the follow-up for this patient. A granular cell tumor on the dorsum of the tongue, around 1.5 into 1.5 centimeter into 1 centimeter with margins involved, ATP are present. So what should be the further treatment and follow-up for these patients? Dr. Tony, Dr. Moni, one of you can take it.
Sorry.
I'm going to leave Moni to answer that one.
All granular cell tumor is a non-specific type of, we have not characterized the lesion yet. So it's just a very morphological type of description. Of
ATP present is the report, sir.
which one?
ATP present.
Yeah, but
Listen, you with ATP present.
you don't see in squamous, I can't say no, you don't, but rare to see squamous cell carcinoma on the dorsum of the tongue, but it does happen occasionally. But we want to make sure that we are dealing with a carcinoma, okay? And then squamous carcinoma, then of course that needs a wide excision with a negative margin.
Okay, fine, thank you. Neera sir, the app is great actually, and now exactly how do you think you are going to promote the app? I mean, one point, and second thing, how do we do it at a community screening level for the same app? Because the app is actually good. So, what is your now next plan for increasing the app usage actually?
So I would
Not an app
actually
at the moment, right?
Yeah,
It's not an app at the moment.
It's a hybrid application, so you can use it on mobile, laptop, desktop, anything. So this is the next version of the mobile application. Now people are moving away from the application and they are like having a hybrid application.
Yes, because there are too many apps. People don't want apps anymore actually.
So then, so as I listed in my PowerPoint presentation, there are 3 ways that I can. One of the things that I really would like to do is, maybe associate with a dental association or IMA or something, and say you can give a free access to all the clinics. They can download the banner from the website and then they can put it onto the clinic, and whoever wants to do it can do it. That's one way. Second way is approaching, some funding agency to run a pilot into 2 or 3 districts. So what you can do is you can have a training, PHC-wise training of all the ASHA workers and health workers, and see if it's a paper form or a mobile application directly will work. So most of the state government have there some kind of an health portal. So ours is an open-ended application and we can actually just connect to them. So in their health portal, which ASHA worker is already using, most of them have some kind of a mobile given to them. So this can be integrated. So that's another thing. And third thing is I can actually, if some funder, some NGO or something come, I can directly go to media and newspapers and digital media and all that, and directly reach to the people themselves to do it. So that's what is, I'm doing it as of now in the background. Maybe hopefully in a year or so we can.
So sir, if there are units or if there are doctors who are into treatment of oral cancer or any specific onco which is getting screened and they are into this, is there a way to like from your side to direct the patient to that area, because their patients will be getting about the app in that area, that perimeter of radius being screened. So how do you plan to direct them to those patients?
So basically, if you look at the entire website, it's not only for prevention, it's also for cancer patient support. So it's like from start to finish, everything comes. We are also building tobacco de-addiction program, which is like a self-learn program, other thing. So all the oncologists who will actually register for this application to be used in their hospital, there will be a find a doctor kind of a search area for people. So they go there and they use the filter like country, state, and district. Then they will get a list of oncologists available in that particular area. And then there'll be a contact details and all that. They can contact them and go for. So that entire thing is built in. Some bits and pieces are still going on, but that's the aim. It's basically the aim is to say this is like a support system for an entire oncology fraternity. For oncologists can use this to support their patient, to get new patients. Cancer patients can benefit self-support during and after treatment. So it's like stepwise support for every type of cancer. And common community can use that for a screening or a tobacco de-addiction. So it's like trying to do the entire thing in one.
Right. Thank you. Dr. Tony? Sir?
You've muted yourself.
Am I audible now, sir?
Yes.
Yeah. So, sir, in your OP, there's a question about, is there a difference in staging at which the patient presents to your OP in the first appointment between different races, like in a racial predilection? Is there a difference in the staging of the patients who are coming? Specific race to later age, and is there? And I think Dr. Moni can take it after you, because sir has been there for quite a while. And
if
now
you're
he's
talking
back in
about
India.
different races or different ethnicities, what you're really talking about in the United States is what we call healthcare disparities. And they're basically, and like everything in the United States, it's based on money. So yes, people who don't have money present later with later stage diseases. And do they tend to be ethnic minorities? Yes, of course they do. So they're mainly African Americans and Latinos. The ones who do best are, in fact, the Asians. And by Asians, we mean Chinese, Japanese, and Koreans. They present the earliest. The Indians, funnily enough, present second earliest, because most of our Indian population is very well educated and is working in the IT industry, so they are very knowledgeable. And the Caucasian or white population actually come third in presenting for treatment. But
Right,
that's a very American thing. It's probably a very California thing, for all I know.
Moni sir, how was your take for the same?
Can you just say the question one more time? I'm sorry, I just got
Is there a difference in the stage presentation according to the different races? Because you have been in a single OP, you have seen different races. Like now you're totally in India, that's a different story. But when you were seeing OP with different races, so is there a difference in the stage presentation in the first appointment?
First, I think I agree with Dr. Porter that it's primarily it's because of socioeconomic status. So I work in a very underserved type of population I serve, and almost all the patients come with advanced stage. No question about that. That is primarily because of the lack of access. Access is directly proportional to the economic well-being of a person. Okay. Having said that, one of my students did a very interesting review, analysis of the education status and compliance to the guideline. Okay, that the outcome was very interesting. The more educated you are, less compliant in the guideline. Okay, and then that was a very puzzling question for us. And then we got into details and found that the more educated you are, the more chance, or wealthy you are, more chance you shop around. The more shop around you do, you get poor lack of compliance. Now, poor patients come, they don't have no option. They come to the public hospital like mine, and they do operation, radiation, nobody else to mess around with them. I think if they get an early diagnosis, the poor patient get a better outcome in our country.
That's a very good point, sir, because I think I have a similar experience in my setup as well, because that's another poor population that we deal with. But there's a lot we want to discuss, but I think it's time up now. But couple of points Dr. Srijan has put here is that can there be a national protocol that it becomes medico-legally essential to do something definitive if an oral ulcer doesn't heal in 2 weeks? Do you think something like that is possible in a country like ours, where protocols are many, but nothing is really implemented at the ground level?
That is impossible to do that. It's a purely a clinical decision. You cannot mandate how to manage an ulcer, because it's really educated people. You cannot enforce, bring in law to make a decision. Education is the key.
Education is the key.
Diagnosis is not because of of lack of law. No, it's because of several other reasons.
And so the standard surgical margin for oral potentially malignant excisions
protocol.
Dr. Fogel is a authority in that. surgery for oral potentially malignant.
Margin, sir. What margin will you take for potentially malignant lesions?
Okay. He doesn't want to take, let me take it. Okay. So what we do is we don't necessarily, as I said in the first patient you discussed, we have to take a wide margin. I'll take 1 centimeter margin, but definitely there will be dysplasia in the margin. Mucosa without dysplasia is difficult to get. Okay. And then, so I normally go with 1 centimeter margin if possible. I don't go deep.
As Moni says, the problem is you often can't get margins. There is dysplasia right up to and beyond the clinical margin. So you take a clinical margin, but you find out that histologically, it's actually not a margin. And sometimes you can't get one. You know, it's a field change. So you get what you can, essentially.
So basically, I think you can get two type of premalignant lesion. One is very localized one. And the
Yes,
ones
sir.
which are very localized one, you can actually aim as what Monisa said, more than a centimeter, at least on the surface. But in the depth, you need not go as deep as what you would go for an infiltrative cancer. Maybe
Right, sir.
mucosa, submucosa, and part of the buccinator or something. It should be fine. And the ones which are actually generally very diffuse and all, I personally try to avoid surgery and keep them on a close hold, close observation. If you really have a pinpoint local area, then you try and target that, because it's very, very difficult for a field oral cancer to do a surgery. As like Monisa said, you are never going to get a margin. Are you actually, helping a patient or not?
So are you saying even for, sir, when we get very high dysplasia, like severe dysplasia as a biopsy to observe? Like,
So see, I'm just saying a scenario where you have a complete premalignant changes, both buccal mucosas with submucous
lip,
fibrosis, with
yes,
tongue,
yes.
lip, everywhere. What are you going to do with that? There is an option, just an alternative kind of thinking, that you can actually have a very close observation if you talk to patient very nicely and say, because dissecting the entire mucosa of the oral cavity, I don't think, so unless you have a very pin or a localized area where you are really suspicious of, and you
Yes,
think
sir.
that this is going towards malignancy, then you can target that. But otherwise, very, very difficult to take the entire oral.
So just an
Dr.
Moni, sir.
Dr. Amelia has a very important point here in the chat box. According to her, she has done a study in Newark which showed access to healthcare and race as more important predictors than education, gender, and financial status. I think that's a very important point. And at this point, I think we'll have to call the end of the session. Thank you so much, everyone. Do we have Amit with us already?
Yeah, I'm
Amit?
just logged in. I just
Yes, Amit.
reached 10-15 minutes.
Please do the AOMSI closure for us.
Yeah.
Thank you so much.
I think Preetam is here. Preetam.
Yeah, Amit, I'm here. Go ahead, Amit.
Thank you, everyone.
So
Thank you, Preetam.
thank you, everyone. It was really a wonderful session in the car. I was listening it on YouTube, and I'm sorry because of AOMSI fellowship exam, I was traveling from Chandigarh to Amritsar, and it was a wonderful session. Moni sir, as usual, it was really informative. Dr. Pogrel wonderfully explained. Dr. Praveen, you very well explained about the community, at the community level, how we can go about, and we missed Pankaj Chaturvedi sir. He should have spoken how we can work with the bureaucrats and at the policy level, making the policies in India with such a large population and having the very big cancer burden with the use of tobacco. And we need more preventive strategies than the molecular markers and all those things. We need more preventive strategies and awareness things in our public as well as in the surgeons at primary health level. And of course, Dr. Neerav Trivedi wonderfully explained. I would pass on to our Honorary General Secretary, Dr. Preetam Shetty, for conclusion.
Thank you, Amit. Thank you, all the panelists, speakers, and participants for joining us today. Thank you. Shilpa, can you play the web series music to end the session, please?
Thank you all. It's been great fun.
Thank
I
you. sir.
enjoyed it.
Thank you, sir.
Thank you.
Thank you.
Okay.
Thank you all.
It is now 7:15 in the morning. I don't know whether to go back to bed or not.
But we know that we are going back to the bed.